Now let's dive into today's topic, periodontal disease, causes and implications. Please join me in welcoming Dr. Frank Tsai.
Thank you for having me. Get set up. So my topic today is on periodontal disease. What is periodontal disease and what to expect from your periodontist or your dentist. And just a little bit of background about me. I have no financial disclosures to disclose. I have no conflicts of interest. I only present as a volunteer, and I don't have any commercial relationships, nor do I endorse any particular product in this presentation. I'm local to Los Angeles, and I did my dental school in Boston University, did a 1-year GPR in New York, followed by residency in periodontics at NYU, got board certified. I'm a volunteer faculty at USC. During COVID, I also got a master's in oral facial pain, and I'm working towards my fellowship in the AGD and Kois Center, Kois Institute, as well as the Pankey Institute, to finish their curriculum as well. My history with Tsuji starts, I was one of the original Chinese school graduates from Monrovia, and I started volunteering with TIMA early on, before high school. When I moved to Boston and then New York, I still continued to volunteer, especially with the Tsuji International Medical Association. We did a lot of fundraisers. Also, we did a lot of outreach in New York. And then on the far right here, this is the more recent ones in the last 2 years, where we would go to Santa Ana, San Bernardino, Bakersfield, and just try to do the dental outreaches for the patients there. And the key was to improve the access of care for these patients. And so the reason why periodontal disease is so important is so this paper is actually from 2016. It's by Montserrat, and it highlights the importance of periodontal disease with systemic associations. So each part of the pie graph represents how many registers are in the PubMed system with regards to one part of the body in relation to periodontal disease. And each one of these little bars represents the strength of association. So, for example, this is going to be about cardiovascular disease, diabetes. This is musculoskeletal, the lung. This is for pregnancy complications, as well as chronic kidney. So I do want to highlight that one of the links is through inflammation, through the oral cavity to the other parts of the to the organs. So I do want to highlight some associations specifically with cardiovascular disease, diabetes, obesity, rheumatoid arthritis, pregnancy, and kidney disease, and Alzheimer's. So, for example, in the plaques found in heart attack patients that are still living, they were able to find P. gingivalis and AA. Those are two particular periodontal pathogens related to periodontal disease, and they found it in the plaques of heart attack victims. And periodontal disease is associated with cardiovascular disease, definitely obesity. Rheumatoid arthritis patients have worse attachment loss, tooth loss, higher cytokine levels. It's definitely associated with chronic kidney disease. And in living patients with Alzheimer's, they were able to find in the brain P. gingivalis, the bacteria with their enzymes, gingipains as well. So we think that inflammation is the link. And so how does periodontitis affect the systemic health? Why does periodontitis have so many associations? Well, let's start by asking, what are the players involved in gum disease or periodontal disease? And so that will be plaque and biofilm, calculus, dysbiosis, and inflammation. And so I want to start off with biofilm. So biofilm is a community of organisms. They adhere to almost everything, including water pipes, drains, metal objects, but they also adhere in the body as well. And they're encased in a extracellular matrix. Basically, it's connected and it protects this community from environmental stresses. Because of this, it's able to resist a lot more antibiotics than compared to free-living bacteria. And then plaque, this is on the left here, is an organized mass of microorganisms embedded in the matrix of essentially sugar and proteins. They contain bacterial products, enzymes, food debris, and they also contain calcium and phosphate. So this is an example of plaque clinically in the mouth. It's around the teeth here, a little bit haziness. This is an example of the community of bacteria and a different microscope version of that. And when the plaque starts to mineralize, it becomes something called calculus. And that's basically a hard concretion, and it sticks to anything, the teeth, your restorations, your crowns, anything that's in your mouth that's long term. And so these are examples of calculus. So you can see around the root of the teeth here. This is an example of a tooth I took out with the concretions there. Same over here. And on the x-rays, it looks kind of like these little protrusions sticking out, these rough areas. Another one's right here. And another example will be this one right here, in between here and in between there. And so inflammation is the consequence of prolonged plaque or calculus on the teeth. And so it's a natural protective condition. Your body responds to trauma or microorganisms by with your immune system providing immune cells through the blood vessels to that region. Typically, it's either self-limiting or it's not self-limiting. It's either acute or it's chronic. Some other names for inflammation will be swelling or gum swelling. And the four main symptoms, clinical signs of this, it will be bleeding, redness, swelling of the gum margin, and then swelling of the gum tips. So here's some examples. On the top, it'd be like on this redness right here. This is a swelling of the gum tips, the papilla, and this is an example right here. And then this would be swelling of the gum margin, which is a more exaggerated example right here. So this is an example of someone with healthy radiographs, so healthy x-rays. There's not much bone loss. There's not much evident of disease. So this is a healthy individual again. I do want to show that this is the crown top. These are the roots, and essentially there's bone to the top where it should be, okay? And this is an example of someone with gum disease. There's some attachment loss, there's some bone loss going down right here. So it's nearly halfway down. There's something going on the root here as well. Further examples, this is an example where their bone should be somewhere up here. It's gone nearly to the bottom. It seems kind of rough on this root as well. Something's going on this root as well, and something looks kind of rough here as well. These are a full mouth series version of that. So this is an example of a tooth that's the bone has gone all the way down to the end of the root. There's something going on there as well, on this tooth, and again, something's going on right there as well. Another example of a severe presentation of gum disease. This has gone all the way down. Something's going on the crown here, but more importantly, the bone around here should be somewhere on the top. It's gone nearly to about 75% gone. So these are examples of people in different stages of the disease, and I'll explain the different stages in a moment. So how do these players interact to cause disease? Well, the disease presentations will be health, that leads to gingivitis, and that leads to periodontitis or periodontal disease. And we use those interchangeably. So the first model that I kind of want to show is the 1997 classical model. So this red represents the microbial challenge. Normally it's plaque. And so at some point, there's a lot of cross interaction with your immune response, which is going to be the inflammation right here. There's a lot of once the imbalance is created, then there's going to be some enzymes that ends up going into your connective tissue and your bone, and finally that's presenting as gum disease on the far right here. So that's your final presentation, and then your inflammation response is modified by the genetic risk factors as well as the environmental and acquired risk factors. So it's amplifying the inflammation or modifying the inflammation. This is the 2012 keystone pathogen hypothesis. This model believes that the bacteria is the main initiator and the driver of the dysbiosis. And so basically P. gingivalis, which is highlighted in the center right here, is the culprit for this model. And what it does is it initiates the inflammation cycle, and then the inflammation cycle feeds the bacteria for the dysbiosis, and that goes in a circle called a self-feeding cycle of disease, according to the authors. And then the 2020 Impede model, which focuses on inflammation, they state that plaque is a non-specific, the non-specific bacterial plaque is the initiator. That initiates the inflammation. That's the driver of the dysbiosis. And that dysregulated inflammation that feeds the dysbiosis and the bacteria that feeds the inflammation, that's called a self-sustained feed-forward loop. So there is a controversy about what starts the disease, but what we can all agree on is that plaque, dysbiosis, and inflammation are all involved in periodontal disease. So whether you have this presentation, or this presentation, something complex is going on underneath the gums. And these presentations don't look all that different, clinically to someone on the street. But what we want to highlight here is this is the dysbiosis, that's the bone resorption, and something really complex is going underneath the gums to cause disease. And so I want to use this particular model because it's one of the more easier models to understand. So I do want to highlight that they highlight diabetes and smoking as very, very important factors. Diabetes and smoking impair the neutrophils and the wound healing process. Smoking is definitely associated with periodontitis and specifically grade C periodontitis. Obesity has a big factor as well. And and your diet has an interplay as well. Lately, in the last 2-3 years, there's been a lot of papers on vitamin D deficiency and also processed food diets. They indicated that there's a relationship between daily intake of processed food and the risk of diabetes. And these are the genetic polymorphisms that exist. Basically, there's not much we can do about the gene portion of it, except that I hope the patient can understand that their inflammation system may be modified for the worse if they have a specific genotype. So health, at some point, there's a plaque accumulation that leads to calculus. There's inflammation involved that feeds the dysbiosis. It's going in a circle. That's the loop. It's modified by the disease modifiers that eventually we'll have gingivitis, eventually we'll have periodontitis. So that's the pathway. And that's why systemic disease, it ties hand in hand with periodontal disease. And so there's no cure, just like diabetes, just like heart disease, there's only management. So again, to reiterate, plaque becomes inflammation, plaque initiates inflammation, which drives the dysbiosis, which leads to attachment loss. I'm kind of alluding here that these pictures on the left will be non-surgical therapy, and the pictures on the right will be some sort of surgical therapy for periodontal disease management. And so I just want to show you some clinical presentations, some obvious presentations of the different stages of periodontal disease. So health, gingivitis, and the disease. So this is an example of a healthy individual. And there, according to the definitions, there's at least 4 different types of when you're healthy, of which I want to focus on 2. The clinical periodontal health, which is someone that has not had periodontal disease, and especially on an intact periodontium. And someone that had disease but was stabilized, we call that periodontal disease stability. The main hallmarks of health is going to be absence of BOP, which is absence of bleeding and probing. That indicates there's no inflammation. So this is the case, 25-year-old Asian female, no medical problems. The gums look pretty healthy. There's very minimal bone loss. Clinical diagnosis was clinical gingival health on intact periodontium. These are some of the x-rays. Here's a full mouth series. And then gingivitis. So gingivitis is an inflammatory lesion that it's a reaction from biofilm and your host immune inflammatory response. Because it's confined to the gums, it does not extend beyond that into the bone. So at this point, we consider reversible as long as we can reduce the levels of the dental plaque. So the main signs for gingivitis will be bleeding, redness, swelling of the gum margin, and swelling of the gum tips, which is the papilla. So to kind of summarize, if there's no pockets, healthy will be less than 10% bleeding sites, and then anything above 10. So 10 to 30 is localized, and over 30% will be generalized. Again, the signs. So this is an example of a patient with plaque-induced gingivitis. There's no minimal pockets. I understand that this tooth does not look so great. And then inflammation around the gingival margin here with a little bit more pronounced there. After performing scaling root planing, then this is how it looks after we tighten the gums up, after the inflammation has been resolved. And if the inflammation and the inflammatory lesion extends into the bone and results in bone loss and attachment loss, then we call that periodontitis. So the main features will be loss of periodontal tissue support, attachment loss, bone loss. There should be pocketing, and of course, bleeding. So a patient is a periodontitis case if at least two teeth that are not next to each other have interdental attachment loss, and it can't be due to recession, root fracture, endo abscess, caries, or due to a third molar distal to a second molar. So this is just one example of a pretty obvious periodontitis case. This is a 48-year-old Asian male, no medical problems. We diagnosed him as generalized stage 3, grade C. These are his x-rays. And then I took another final full series myself. And this chart shows anywhere between 1 millimeters and 9 millimeters for the top. Again, 1 millimeter and 9 millimeters on the bottom. For the plaque index was 100%. For the bleeding index was about 60%. So to summarize, health represents no bleeding, which equals no inflammation. Bleeding, but no pockets, represents gingivitis. And if you have all the above, bleeding, pocket loss, bone loss, then that's called periodontitis. So this is one of the more severe examples. This is a 20-year-old Asian male, no medical issues. You can see the inflammation over here on the main, on the gingival margin. He's losing a lot of teeth. I diagnosed him as generalized stage 4, grade C. And this would be the classic molar incisor pattern. So this is an example of the gum margin and how far the inflammation has gone. The x-rays. And I also showed a sample of his dysbiosis. So this is a saliva test that measures the bacteria. This is going to be the AA. This is the dysbiosis, which is the red complex bacteria, which is associated with gum disease. This is his orange complex and his green. So whether you're doing implants or orthodontics or Invisalign or root canals, it's important to have periodontitis managed first. So this is an example of a tooth that was referred for a root canal, but basically there's a lot of attachment loss on this tooth. So this is one of the things that we should check for before, like if we want to do any extraction first or any treatment first before doing the root canal, before investing more heavily. This is an orthodontic patient that, during braces, the gum margin has swelled to the point where you can barely see the teeth. This is a patient that presents for orthodontic evaluation. This is a 24-year-old Asian male, and he's never been to the dentist, at least in the United States. You can see that there's buildup here along the margins, along this tooth as well. So prior to doing any orthodontic treatment, we need to treat the gum disease first, which we did. This patient came in for evaluation for implants in this lower right region, but he has other issues going on, infections on these two teeth, a lot of bone loss. He hasn't been to a dentist a very long time as well. So prior to doing implants, we should definitely treat the gum disease first to see if we need to do any other to stabilize all the rest of the teeth as well. So this is the same patient. So how to determine if you have disease? Whether you have this presentation, this is an 18-year-old female with gingivitis, whether you have a 33-year-old male with stage 3 grade B, or a 52-year-old female with stage 3 grade B, or stage 3 grade C. Whichever presentation you might have, you should definitely visit a dentist. So now that you've decided to visit the dentist, what should you expect from that first appointment? Well, we're going to do a very thorough process. It includes medical history, clinical examination, periodontal charting, radiographic examination, as well as diagnosis and the treatment plan. So, of course, the past medical history is the reason why we check is because there's a lot of systemic associations between periodontal disease and the systemic health, which we talked about earlier. For the radiographic examination, we might take a full mouth series, maybe an orthopanogram, maybe a 3D scan. I highlighted the full mouth series because that's more important to a periodontist for diagnosing. We're looking at these set of things here. I'll go into detail in later slides about what these actually are. How many radiographs do you need? I always say that you need enough to diagnose. And how often do you take the radiographs? And I always say, if the mouth does not match the radiographs, we need to take some more. For the periodontal examination, I'll be going through this with you as well, measuring the different aspects of the chart, and also for the clinical exam as well. It's a very thorough examination. So medical history, we need to have a thorough medical history. So I pay special attention to things like heart attack and stroke, diabetes, rheumatoid arthritis, osteoporosis, atrial fibrillation. And the reason why is because there might be a lot of medications that interfere with potential treatment that I may perform. This list includes things like blood thinners, osteoporosis medications, cancer therapy, especially bone cancer. I always want to highlight calcium channel blockers and antidepressants. We pay special attention to antibiotics, allergies, any allergies, but specifically allergies to antibiotics, aspirin, and codeine, and smoking status, because cigars, and at least in America, marijuana. So this is an example of a part of the clinical examination. We measure the plaque index and gingival index. Plaque index is just how much plaque is on the teeth. This picture on the top shows that plaque is somewhat invisible to the naked eye. We can put a disclosing tablet on it, and it shows up as pink. And then we essentially count the surfaces, and then after we clean it up, we'll do the measurement. This is a patient that walked in about a month ago, and this is a patient that has not been to the dentist a very long time. But you can see that the plaque that's accrued along his teeth that led to the inflammation around the gums. This will be the swelling of the papilla, and this will be swelling of the gum margin here. Okay, so these are some of the things that we will look at: plaque, calculus, your bite, any cavities, any abscesses or infection, whether the teeth is shifted, they have gaps, they moved up, whether any of the restorations have issues, and also anything that contributes to plaque retention that your tooth anatomy might present with. This is an example of the periodontal charting. So this is quite a lot to talk about, but basically we use a probe to measure into the gums to measure how deep the site is. Essentially, the deeper the number, the worse off it is. So specifically, I'll go through each one with you. I just lined the title up with the chart, but I'll be looking at pocket depth, recession, bleeding and probing, and furcation. So this is an example of measuring the pocket depths. This is a healthy individual. This is a cartoon, of course, but this is a healthy individual with measuring into the base of the pocket. And if there's any swelling and bleeding, then when you measure, it might bleed, and we call that bleeding and probing. Typically, we measure 6 sites around the tooth. This is how it looks on the charting. And recession. So if the gums recede away from the demarcation between the top and the bottom, the crown and the root, then we call that recession. So this is an example of a clear example of a recession site. And then where the root splits, specifically on posterior to the back teeth, the molars. This example, we can take a curved probe and measure into that area. So this is the example of buildup that extended into the furcation, which is this root split right here. Example, again, right here, that's the root split. This is the buildup. And another one, this is where the root split and the buildup extends into that region. And this is on the X-ray. You can see that there's a dark site here. That's the radiolucent site that represents the furcation involvement. This is an example of a healthy individual that I made up. Basically, pockets no deeper than 3, very limited plaque, very limited bleeding. This is the patient that I made up. That's would be a severe case, anywhere between 2 and 7. That I posted it for the pocket depths in this example. And on your X-rays, there's 3 types. There's full-mouth series, orthopanogram, and the cone-beam CT. So, which I specifically want to talk about the full-mouth series at this point. This is a healthy individual, but this is part of a series that shows different aspects where there's buildup here, built up there, built up right here. And this is an example of an orthopanogram. This is something that your dentist may take. And this is an example of a patient that has a significant amount of disease with a bone loss all the way to the root here, infection going on right there, as well as something going on right there as well. So at this point, I do want to talk about the different things that we'd look for. So for example, calculus, which is the hardened buildup that we're looking for, that these are examples here, and also right here. And then bone loss would be, for example, the bone levels are here, and all of a sudden it's gone halfway down on this particular tooth. Furcation arrow is a little notch that's in between on the molars. Sometimes it's there, sometimes it's not. Open contact will be this gap in between teeth, represents a space between these two teeth. Okay, supereruption, this tooth may be supererupted compared to the neighboring one right here. It's basically coming out slightly. PRL means periapical radiolucency. So this would be a classic example, something around the root tip here, and also definitely something around this root tip right here, okay? So just basically a dark circle around the base of the root. And lastly, caries, which means cavity. This would be example right here, and another same tooth right there, that dark circle right there. So example of a PRL, periapical radiolucency, would be this tooth number 15 here. And then after we took out this tooth, that's what's inside there, the soft granulomatous material that's been there. So at some point after collecting all this data, your dentist should give you some sort of diagnosis. These stages represent how severe and how complex we anticipate it to be. That's usually based on some sort of hard measurement like pocket depths, bone loss, furcation emallment, and clinical attachment loss. And then the grade will be features that make it worse. So diabetes and smoking are implicated in this as well. And then whether it's localized, generalized, 30% or over, or the molar incisor pattern. So I kind of made this table for everybody, basically to help people diagnose. It includes pocket depths, bone loss, attachment loss. I also included just some general pictures to show you like what the presentation may be like, may present as. And with traditional therapy, the treatment plan, if you're healthy, typically you need some sort of cleaning, whether it's prophy or maintenance, okay? Gingivitis is usually treated with scaling in the presence of generalized moderate or severe inflammation, or possibly a deep cleaning. And then periodontitis usually has some sort of deep cleaning, which is scaling and root planing, some sort of surgery option, as well as extractions. So basically, to kind of group it, it's a cleaning, a deep cleaning, surgery, or extractions. This is the traditional algorithm. So I just kind of showed you a complete workup. This is a patient that presents, 52-year-old Asian male. I looked at his medical history. He's a non-smoker, no allergies. After taking a look at this, we took the x-rays, we took the full mouth series, and we diagnosed him as generalized stage 4, grade C. And this is his paracharting. The pockets range from 1 to 11. And I gave him a complete treatment plan. So your traditional treatment options, typically for health, is some sort of cleaning, so whether it's prophy or maintenance. If you have inflammation and gingivitis, at some point you may be doing scaling or scaling root planing. And if you have periodontitis, periodontal disease, it's either scaling root planing and also including osteosurgery with potential extractions. And just to kind of throw it onto this matrix, basically, if you're healthy or gingivitis, it's prophy, maintenance, or scaling. Stage 1 typically is deep cleaning for traditional options. Stage 2 is deep cleaning as well. Stage 3 would be this plus potential surgery options like osteosurgery or regeneration, and also possibly extractions for stage 4. So this is an example of traditional therapy for scaling and root planing, which we call deep cleaning. Typical steps include delivering anesthesia, which helps keep the area comfortable. Scaling, which represents cleaning the top portion of the crown to remove stains, plaque, any buildup. Root planing is cleaning of the root surface down here, and that's to remove any plaque, any calculus, as well as remove any disease cementum, like the covering of the root that might be impregnated with any toxins. Okay, and then gingival keratosis, which means to clean the gums as well. Typically, it takes about 1 to 2 hours per visit, and typically we tend to separate into half mouth or versus full mouth. We separate the mouth into quadrants. It could be uppers, lowers, it could be right side or left side. Just depends on your dentist. And typically, there's very minimal discomfort, minimal bleeding after you head home. Typically, there's no antibiotics required, usually, okay? And you might be prescribed some sort of rinse, typically. So these are examples of before and afters of just different patients. And the next few slides might be sensitive content. There's going to be a little bit of blood, so if you're a little bit if it's hard to handle, then please for the next few slides just be aware. Okay. So traditional surgery is called osseous surgery. There's two parts to osseous surgery, and that's called osteoplasty or ostectomy. Basically, are we moving bone around the tooth or away from the tooth? So ostectomy would be removing supporting bone, which is around the tooth, and osteoplasty would be anywhere away from the tooth support, which might be up here. Okay. So these photos are from the perio.org, the AAP website. If you just search their glossary of terms, osseous surgery, you'll see these pictures. This is from the famous Daniel Melker, and this is called biologic shaped teeth. He posted these pictures for reference. Basically, this is before and that's after of his work, just to show people what osseous surgery is. So typical steps include delivering local anesthesia, because it is a surgery. We want to make sure the patient's comfortable. We open the tissues, we clean the teeth, we correct any osseous defects, which is the changes to the bone. If we can, we rebuild if possible. We put the tissues back and we suture it together. Here's an example. This is from my time at NYU. And this is an example of my incision design. Once I flapped it, you can see that there's a crater here, some ledges here that we want to smooth out. And this is after suturing. Typically, periodontists can do 1 to 2 quads per visit. It's about 1 to 2 hours usually. Typically, there's 3 to 7 days of mild discomfort. We do manage that with analgesics and antibiotics if required. And we do typically prescribe some sort of rinse just to keep the bacteria count and prevent infection if it's indicated. Sutures typically dissolve in about 7 to 10 days. So for that case, this is the before and that's after. And what you can appreciate is that this has some recession involved with the surgery. Some pros and cons. The benefit of doing surgery over deep cleaning is that for sure you can access the buildup, especially underneath the gums. It does have superior pocket reduction numbers compared to deep cleaning, and there's a relatively low infection rate for these type of surgeries. But the consequence is that there is some recession. Typically, it's 1 to 2 millimeters, and if you do the incision a different way, it's called a submarginal, it might be even worse. So the focus of the surgery is just to cut the gums away. Essentially, if you treat the pocket dips, you might leave with a recession. And then my question is, what if the disease returns? How do we treat the dysbiosis if we don't verify it? And then how does it contribute to resolution of inflammation? How do we reduce inflammation with osseous surgery? So my classic example for most periodontists is, what if we have pocket dips of 3 millimeters, but there's a significant amount of bleeding? What's the treatment of choice? Some modifications of surgery include trying to grow some bone back, and we call that regeneration. So these are some materials that for bone grafting. So typically it's cancellous bone or some sort of mix. For the membrane, which is the cover of that, called guided tissue regeneration, is typically 2 types, which is resorbable collagen or non-resorbable, which is titanium reinforced PTFE. And some sort of biologic. This is called an enamel matrix derivative, and this is called platelet-derived growth factor. So these are 2 cases that I did in the past. I used these 3 materials, and this is an example. This was an abutment tooth for a bridge. It was non-mobile, so after the patient elected to try to save it, we cleaned out this defect. We packed these 3 materials into the site, and this is about 4 months later. The bottom here is he's an 18-year-old male, and there was a primary tooth root tip that was in here. We took it out. After a while, we realized there was a significant bone defect. We cleaned this out. We packed these 3 materials inside, and then this is about 4 months later. And extractions. Extractions really aren't a form of periodontal treatment. the consequence of the treatment and dealing with it. So I included it, but it really does nothing to fix the disease, which is the dysbiosis and the inflammation. So this is an example of a lot of teeth that I've taken out. And this is where most of my teeth belong. And this is the maintenance protocol. Typically, we need to maintain the teeth, especially to prevent recurrence of disease, to try to prevent tooth or implant loss, and to try to locate and find other diseases early on. So include some sort of examination for the dental, for the periodontal examination, evaluation of the implants if required, some sort of x-ray examination, evaluating their oral hygiene for the patient. The treatment involves cleaning of the top and the bottom to remove plaque and calculus. We typically want to reinforce good oral hygiene habits. If we need to do anything adjunct, we do that. And as well as planning the recall intervals and the frequency. And this is all actually from the 2003 AAP position paper. So this has been around for about 20-something years. And this type of maintenance protocols should be tried and implemented in most practices. This is how we can keep our patients monitored. And so the goal is to establish a stable periodontal state, to establish a maintainable state, establish an oral hygiene routine that keeps your teeth clean and healthy. You should visit your dentist at regular intervals and visit your dentist before an emergency occurs. How to determine if your disease is stable? You have to establish history at an office. And how you typically do that is by visiting them at least more than once. The question is, if I see you for the first time, how do I know if your disease is stable or not? Typically, healthy patients come at a 6-month interval. This is if they never had disease. If you had disease, you should probably go at a 3-month interval to try to maintain that or slow the progression down until the treatment is complete. And if you're stable, maybe we can extend that to about 4 months for the interval. As a periodontist, my goal is to typically, for most of my patients, my goals are to eliminate plaque and the dysbiosis, to help eliminate, reduce, or modify the inflammation, eliminate, reduce, and improve your risk factors. As a dentist, my goal is to prevent or minimize the recurrence of disease, to prevent or reduce the incidence of tooth and implant loss, try to find diseases early on, and try to treat it early on. As a doctor, my goal is to continuously monitor your periodontal condition, your dental condition, your oral condition, and your systemic condition, find things early, and treat it effectively. And the goal for my patients, I hope my patients will have good personal oral hygiene, as well as communicate with their provider. Any small changes may reflect in big things down the road. And how do I know if I'm succeeding or failing? Well, if I can't control the bacterial profile, if I can't control the inflammation, the risk factors, if the patient's continuing to have disease, they're losing teeth or the implants, if they're showing up to the visits very infrequently or not showing up at all, or the oral hygiene is not so good. These are things that we might evaluate to be potential causes for failure. In America, we would usually say that an ounce of prevention is worth a pound of cure. So I compare this like a real world situation. The barnacles on a boat are kind of hard to treat, similar to the calculus that's around the base of the teeth along the gum line. By the time you realize there's a problem, it's probably too late. So it's easier to mean something like this when there's never a problem at all. So treating a problem is a lot harder than preventing the problem. It's also more economical as well. These are some things that can help prevent. So the best policy is to never develop periodontal disease, and to help that, I just want to improve awareness, prioritize your oral hygiene, and maximize your health. For example, awareness is basically education. So try to have great hygiene practices, have regular checkup, visit your dentist, have good cleanings, maybe improve some of the awareness for your health and your diet. A lot of things are coming out for sleep science and how you rest and how you recover. Maybe learn about potential environmental toxins. A lot of talk these days about microplastics. For your oral hygiene, daily plaque removal. Hopefully that's regular, high quality brushing, flossing daily at a minimum. Any adjuncts to help you in that journey, whether it's a water floss or interproximal brush, any rinses to help decrease bacteria, whatever you want to choose to help prioritize your daily plaque regimen. That's good. Maximize your health, improving your overall health, like things that decrease inflammation, maybe increasing antioxidants. Some foods like that are like spinach and blueberries. Supplements, talk to your doctor about this. Maybe talk to them about supplement for vitamin D or omega-3s. This is something that your doctor can give you a little bit more information about. Improving your diet. Maybe consider less red meat, definitely less processed foods. Improving your daily routines, stress reduction, mental relaxation, meditation. Evaluate your sleep routine. Try to get abundant and consistent rest. So I just found some emojis to help kind of show this. These are the foods that you probably should eat more of. And these are the foods that you should probably reduce in your daily intake, hopefully. These are things that your dentist is having. And these are things that your dentist is trying to fight. A lot of sugary substances. These are things to help reduce stress and maximize your health. Things that like yoga, relaxation techniques, stress reduction, exercise, and then maybe meditation and religion for some individuals. Definitely less smoking or no smoking and lots of rest. So this is already probably too late. This is something that we hope to catch and treat and hopefully deal with. And this is help maximize your oral health, your overall health. And on the next episode, specifically for dentists, I hope to try to illuminate on how to improve on their models of pathogenesis, as well as different options for plaque management and also inflammation management. Thank you so much for listening today. I appreciate your time. Thank you so much. And here are my references for the different slides. This is for the perio portion of it. This is the systemic association. This is the genetic and the enzymes. This is for the future lectures. Traditional therapy, oral hygiene, perimaintenance. Thank you for coming.
Thank you so much, Dr. Tsai, for such a informative and educational webinar. And I learned a lot about the dental's related clinical terms beyond toothache, cavities, and routine dental clinic. And the best part about today's webinar is it is recorded. So we can always go back anytime at your convenience to our YouTube health channel to educate ourselves. And as Dr. Tsai has said, preventive is the keys. So depends on, so you can help you when you are to start your next dental visit. We have quite a few questions and lots of feedbacks on today's lectures. So I'm going to read out today's questions for Dr. Tsai. The first one is, are dental implants still an option for patients with gum disease?
Okay, so the timing is kind of important. There's a very general philosophy amongst periodontists, and the line is we shouldn't place a sterile thing into a dirty place. And we say that because the inflammation that's still there and the bacteria that's still there, the dysbiosis, can affect implants as well. And so the goal is to treat periodontal disease first, and then once you have it stabilized, feel free to do implants afterwards during the reconstructive phase. There's no indication that there's no contraindication for implants, but during the periodontal disease management side, that's where I would kind of watch out for.
Thank you, Dr. Tsai. So the second question today's audience present is, I brush every day. Why would I still get gum disease?
Okay, that's actually a loaded question. The brushing just deals with the plaque portion of it, but the dysbiosis is the bacterial side as well. So if you have periodontal disease and there's also pockets, there should be dysbiosis present. And that's what your dentist needs to manage, in addition to just cleaning your teeth as well. So the oral hygiene, penetration of the brush into the gums is only 2 millimeters. This is according to hygiene literature, 2 to 3 millimeters. So if you have pockets of 5, you're still not effectively cleaning to the base of the pocket. If you have a pocket of 6 millimeters, let's say, the plaque is supposed to go up to 5.5, which is actually hard for even dentists to clean. So if you still maintain it, you're just maintaining the top portion. We still need to manage underneath the gums as well. So plaque management at home is very, very important, especially after treatment. But you have to understand the top and the bottom is slightly different as well. So managing both is super important.
Thank you, Dr. Tsai. So I think Dr. Tsai, one of the slides that Dr. Tsai showed it, in addition to the brushings, it also including the rinse and floss. So that is all part of the quality of brushings. The third question to present is gum disease reversible if caught early?
Gingivitis is reversible. It's considered reversible because it's still confined to the gums. Once it extends to the bone and there is attachment loss, that's not reversible. Now, there are certain times where you can regenerate. Not every single site can be regenerated. And it depends on whether we can get it cleaned out, whether we can get it contained, and whether the material will grow onto the root, because that's sometimes quite difficult. But to answer your question, it's not reversible once you've had the attachment loss.
Thank you. So the next question is, what are some common habits that can make gum disease worse?
Some common habits. Okay, there's 3 major categories. One of them, the first one is plaque. So if your plaque control is not great, or someone's plaque control is not great, then that will accumulate along the gum margins. That will lead to gingivitis. That will lead to the final disease presentation. So plaque management has always been the focus of most dentists. The second part of it is the inflammatory side, which is the systemic side. So anything that makes inflammation for the worse usually presents worse as deepening numbers. So for example, there's several situations that affect inflammation. Diabetes management is one of them. We definitely look at diabetes, smoking. There's something called pregnancy gingivitis / periodontitis. That's when you're going through pregnancy, the hormones are somewhat out of balance, and it amplifies the inflammation. So recently, I've been seeing more patients that have been going through pregnancy, and their gums are really swollen, really inflamed. So there's if you have lupus, you have autoimmune diseases, rheumatoid arthritis. These are things that your condition might be worsened if you're not managing it well. So that's part of the reason why I mentioned that most dentists should be talking about to their patients their management of their systemic condition. Like, we can't manage it, but at least we can, encourage you, guide you, talk about the benefits of treating diabetes early on, right? And so these are small things that we could do from the inflammation side to when you have a condition. And then the second side, the second category is if you're trying to help overall, well-being, limiting stressful environmental factors like stress, in taking antioxidant stuff, like, eating well, like lots of leafy greens, or taking some sort of, fish oil supplements, something to help your body decrease inflammation. These are things that you should probably talk to your doctor, see what they recommend for you, for each individual. But to answer your question, plaque management, health management, and also promoting a good, healthy environment is the 3 main categories of that 1997 classical model.
Thank you, Dr. Tsai. I think the next question, Dr. Tsai has already partial of that. The question is, what kind of diet helps keep gums health? And should we be taking any specific vitamins?
I kind of want to shy away from giving too specific, because I think your medical doctor should be the one that specifically talks to you a little bit more. I personally have done more research into omega-3s, because omega-3s at some point they get broken down into something called specialized pro-resolving mediators, and specifically that's called resolvins, and that is involved with resolution of inflammation. So that's one of the things that I've been looking into to help give to my patients, and that's a fish oil supplement. So I think that the community should talk to their doctors about this. Omega-3s is one aspect. The other side of it is limiting processed foods. There's some data on less meat. I know this the community is less meat is better. Okay, less oily food. Certain oils are not that great. And so these are small things that we can do on our daily diet to help improve on that. But I don't want to give too specific any answer because I think you should talk to your physician and see what they recommend as well.
Thank you. The next question is, I smoke every day. How much does that affect my gums?
Okay. So with the classification of periodontal disease, it's officially linked and it's officially written in. So if you normally an average presentation that has no medical issues, if you have pockets of 5 or 6, typically it's stage 3 grade B. But if you smoke, you're automatically downgraded to a grade C. So we know that it's heavily linked to it. So nicotine is the main culprit. Typically, it's involved with impairing the immune cells as well. That's why, and we have like 50, 60, 70 years of history with smoking and periodontal disease. So it's definitely in your best interest to try to limit and reduce. What I do want to point out with smokers is that, especially if you're doing surgery, if you're doing major oral surgery, any reconstruction, any implants, it lowers the success rates of most of these surgeries. The heat doesn't allow for good healing. The nicotine's not great. Inflammation looks like it's reduced for a lot of patients. So a lot of smokers that I see, their gums actually don't bleed that much. There's a lot of buildup, but I know something's going on. We all know something's going on underneath. That's why it's in your best interest to limit the amount of nicotine that your body is taking in.
Okay, so I think the next question probably is a little bit difficult to answer. Can you recommend a periodontist in Northern California in the Bay Area, near Oakland or Walnut Creek areas? And I think maybe Dr. Tsai can help us to provide some guidance in terms of, if not referred by your dentist, how do you start the journey to find the periodontist? And is there any kind of the questions that you can present to your periodontist to help you to evaluate or whether that doctor is the match for you?
Okay, so I don't personally know a specific periodontist in the Northern California region, but I will tell you, this is the normal pathway of most of my patients. Either they came because they did some research online, Google, Yelp, or whatever the method of evaluating a dentist, right? And typically that's one way. A secondary way, which I don't know if it's like the best way, your insurance company has a list of providers that they have, and they separate by specialties, whether it's root canal, endodontists, orthodontists, periodontists, okay, or surgeons. And so you can look that way as well. One of the better ways is to talk to your dentist to see who they recommend, who they would recommend to their, if their mother was going to go see a periodontist, where would they go? Okay, because I think that if you already trust your dentist and you value their wisdom and value their expertise, they're likely to have someone that they like, that they're comfortable working with. And that's another way. I get most of my patients through several really good dentists in my area, and I love working with them. They're very they're very knowledgeable already, and they know that when they refer to me, that I'll take care of certain parts of it too. So talking to your general dentist and seeing who they like and who they trust, more importantly, that's another layer to trust that's different than just Google's or your insurance company. So these are kind of the 3 main ways that I've seen people try to find periodontist. The other one is to talk to your medical doctors to see if they have any recommendations as well, because we have a lot of interplay with the medical field. Most of my friends are, some sort of medical related field. So if we're definitely linked in the medical world. So your doctor may know a good dentist or a good periodontist as well. So that's one of the main things that how I would recommend it.
Thank you, Dr. Tsai. So talk to your family doctor or your dentist. And that's the first 2 steps. Yes. And that's all the questions I have from the chat.